Should I introduce myself again? Hi, my name is Taha. I'm a final year medical student, and today we're going to continue on with our exam revision. All right. Well, right. So as with every week, I begin with an apology on my incompetence. So this week, unfortunately, I've gone for breadth rather than depth. So just keep it in mind, and I apologize for that in the future. But at the very least, hopefully we can go through a few topics. There's quite a few topics that we're going to go through. So particularly, we're going to spend a bit of time talking about red eye, and we're also going to spend a bit of time talking about leukemias. All right. So this week, we're doing Revire. We're continuing some of the paper 5 questions, so continued, and then we're going to do some women's health questions as well. All right, so let's start with this. All right, so we have a relatively young man. He's coming to the ED. He's got right-sided, so unilateral. Remember, anything unilateral is typically pathological. Pleuritic chest pain. What kind of things give you pleuritic chest pain?
Pneumothorax.
Yep.
Pneumonia.
Yep. That's very good. Pleuritic chest pain. No significant past medical history. No recent immobilization. Hemodynamically stable, which is a good sign. Oxygen saturation is 94%. What do you think of that?
It's not the worst thing in the world.
Is it normal or abnormal?
It's abnormal.
Is it abnormal?
It's 94 and above, isn't it? Or it depends on what oxygen status.
Well, yeah. Well, what I'm trying to get is it's a normal value. It's not something that's necessarily concerning. However, it's definitely on the lower end of the spectrum. Okay, so just keep that one in mind. CXR, so X-ray, ABG, and ECG are normal. So what what help does that give you? What does the chest X-ray help you to rule out? What kind of things does that help you to rule out? Yeah? Yeah, pneumonia, pneumothorax. How about the ABG? What importantly are we looking for in the ABG? Yeah, okay, so we're looking for any metabolic or respiratory disorders. And especially another important thing is it gives us an indication of the lactate. So lactate is a very good indicator of things like sepsis. So lactate indicates some form of hypoxia or cellular death. So that will go up, especially in things like lactate. And you can use that as a single clinical indicator if somebody's septic or unwell. Okay, and ECG, so arrhythmias, tamponade, anything really major. Okay. So what is the best initial test that you're going to do? Would you do a VQ scan?
No.
Why not?
Because if you're doing that for a pain, you just do a CTPA.
So when would we use a VQ scan? Typically in pregnancy. So that is what the guidelines state. And I was talking to one of my ED clinicians regarding this. And what he was telling me that in practice, people still do use CTPAs for pregnant women. The reason for that is, yes, it's true that the radiation dose is higher. However, for something like a CT, you can very easily put a lead shield over the fetus, which decreases the radiation exposure to the fetus. For something like a VQ scan, where you use an injected radioactive isotope, there's always theoretical risk of exposure to the baby in that way. So guidelines say one thing, clinical practice has another thing, but guidelines is still important. But you wouldn't do a VQ scan? How about a D-dimer?
Same thing.
I would say yes, considering that this patient which had very few risk factors.
Mm-hmm.
So it's good as sort of a screening. I wouldn't go straight to a CTPA in this patient.
Mm-hmm. All right. So CTPA then, based on your logic, would rule out?
I wouldn't do that in this patient.
Yeah. A lower limb ultrasound. Roland.
Yeah.
That should be a clear no. The only reason we do a lower limb ultrasound is if we had clinical suspicion at the very least of DVT. So no, it has no clinical value for people who don't have a DVT. Spirometry. No. So by ruling things out, we would choose D-dimer.
Why not CTPA?
So I'll explain it to you. So by ruling out different options, we choose the D-dimer. And there's a very good reason why. And I want you to know the reason rather than just being able to identify it on an MCQ. Okay, so generally, if somebody comes into emergency department with shortness of breath, what did this man have? He had pleuritic chest pain, okay? He had pleuritic chest pain, so we always want to rule out these three things, right? PE, pneumothorax, and pneumonia. So he has, at the very least, that's a red flag condition that you need to rule out. So you always need to do a well score. So if we do a well score, 1, does he have symptoms of a DVT? No. So he's going to get 0 points there. Any alternative diagnosis? Not necessarily. We're not really sure what's causing his symptoms at the moment. He wasn't tachycardic. He hasn't been immobilized. And this is an important thing. I just want you guys to notice this, right? 3 days. So at least 3 days, or he's had surgery. So it's not necessarily just a long haul flight. And we'll talk about risk factors for PE. Prior history, he doesn't have no hemoptysis and no malignancy. So currently, his well score is 0. So when someone's well score is 0, what you then need to, well, first of all, who knows why we do a well score? Anybody know? Why was the well score developed?
It's like to see like what's the likelihood of it being.
Yeah, so the Wells, exactly. So the Wells criteria was developed to help stratify the risk for somebody to have a PE. So it determines your pre-test probability. So your Wells score, if it's greater than 4, that's a high pre-test probability, and then you can go on to have imaging, okay? So for somebody who has a 0%, a score of 0, their pre-test probability is 1.3%. So in those situations, what you then need to do is you need to do this, which is the PERC rules. Has anybody heard of the PERC rules? They are not. They're very, very different. Okay. So both typically use both together. So what PERC is standing for pulmonary embolism rule out criteria. So in situations where you cannot rule out a PE, or at the very least, if you don't know whether they have a PE or not, so if they're low risk, you can stop investigating or stop thinking about a PE if they get a score of 0 on the PERC rules. But in this case, his score is not 0. So his age is not 50, so he gets a no there. He's normally cardiac, but his SATs are less than 95%. So greater than 95% is normal. 94% you could still argue is normal, but it's on the lower end of normal, so you need to investigate that further. So because his PERC score is more than 0, you need to investigate him. And because it's low, the next test you need to do is a D-dimer, because your pre-test probability is still low, still 1.3%. So once you do a D-dimer, if that's positive, then you can do a CTPA. Does that make sense? All right. So I've just got a quick explanation here. So the reason I've got clinical judgment / well score is because some studies have suggested that using the well score is as good, if not better, than your clinical judgment alone. So once that's done, you then use your PERC score. In this case, 1 criteria is met. And if that's positive, then you do the D-dimer. And if that's positive, then you do the CTPA. Okay? So before I go on, tell me what the risk factors for PE are, and go from major to minor. Imagine you were in an OSCE and they ask you this question. What would you say? So that would probably be more of a moderate. What is your major? There's a few major risk factors for PE. Unquestionable risk factors.
Surgery.
What kind of surgery?
Major surgery.
Well, what?
Orthopedic surgery.
Yeah. So that's absolutely correct. But I want you to be able to, I need you to understand what major surgery is. What constitutes major surgery? A knee is not necessarily major surgery because usually you can mobilize soon after. Hip, yeah, sure, hip. But orthopedic is one, sure. Orthopedics is not always major. What is, cardiac surgery, abdominal pelvic surgery. These are the kinds of things that are major surgery and require long periods of immobilization, requires vascular access, vascular damage, all of these kinds of things. That's major surgery. That's one. What's another major risk factor? Malignancy, so cancer. So cancer undoubtedly is one of the things that can increase your risk exponentially. So the reason for that is, does anybody know who was the first person to describe PE? It was actually Virchow. Who remembers Virchow? Virchow is famous for Virchow's triad. And what's Virchow's triad?
So triad of the issues leading to clotting.
Do you know what they are?
Yeah, so some form of endothelial damage.
Endothelial damage?
Some form of change to the components of blood, so hyperviscosity.
Yeah, hyperviscosity.
And stasis.
Yes, and stasis. So Interesting how Verka was the first one to describe that. So somebody who has cancer has a change to essentially all of those criteria. Somebody who's immobilized has stasis. So if they have a long period of immobilization, note the Wells criteria was more than 3 days, okay? And another thing is any kind of chronic illness. So having chronic heart failure, any kind of chronic illness is a risk factor, a major risk factor for having a PE. So the reason I'm telling you this is because a long haul flight or a plane flight is not a major risk factor, it's a minor risk factor, okay? And what you said before, Alisa, before was correct, pregnancy. Did I say correctly? Alicia, sorry. Pregnancy, hormonal factors are also a very important risk factor. Okay, and then there's other things you need to think about: weight, BMI, cholesterol status, thrombophilia, any kind of bleeding disorders. All of those are important as well. Okay, now just before I go on, Wells criteria cannot be used in certain situations. What is a very important situation that you need to know for fourth year that you can't use it in? Pregnant ladies. So Wells criteria is not validated for people who are pregnant, and you need to use a modified Wells in that situation. I don't know what the modifications are.
Why?
Because for something like pregnancy, for example, for pregnancy, you don't do a D-dimer level. You never do it. The reason for that is in pregnancy, the D-dimer physiologically changes, and they still haven't established what normal D-dimer is in pregnancy. So because of the hormonal changes, because of the physiological changes of pregnancy, Wells criteria is no longer validated. It's not a good clinical predictive tool. Okay. All right. Now, just one more thing before I go on. So in which situations would we choose to do thrombolysis before doing any imaging? So it was in the question. So one thing, it told us particularly that he is hemodynamically stable. So what constitutes someone being hemodynamically unstable? There's one major thing that you can is always pretty much hemodynamically unstable.
Blood pressure change.
Which is?
So go down, I guess.
Right. Do you know what the cutoff is? So typically systolic blood pressure less than 90. So that would be a good indication to do thrombolysis. Or for example, if you do imaging and you see something like a saddle embolus, then definitely you do thrombolysis straight away. The reason I'm telling you this point is because what does anticoagulation do? Does anticoagulation actually affect the thrombus? Well, it does in some form. It decreases it from getting larger. It causes it to be more stable. But the point of anticoagulation is to prevent you from getting another PE. So that's just a fundamental thing that you need to understand, the difference between thrombolysis and anticoagulation. All right, we spent a lot of time on that, but this is from some kind of validated source. I can't remember, it might have been from ICGP or maybe Prompt, something of that nature. But clinical suspicion, he had pleuritic chest pain, Wells score, he had a low risk, PERC rule. Okay, so that's why you need to know a PERC rule. PERC rule positive, first thing you need to do is a D-dimer. So that's why that's the answer to the question. All right, next question. All right, so what color should I use? What's your favorite color? Choose a color.
Blue.
Royal blue, dark blue, or light blue?
Royal.
Okay, so 20-year-old. He has some exertional dyspnea. First of all, this is important. Why is it important? He's quite young, okay? So he's not going to have, it's unlike he's going to have some kind of pathological condition. He has chest pain and palpitations 2 weeks after developing flu-like symptoms. Flu is usually due to a virus. So he's had some kind of virus. No prior medical history. Temperature is 36.8. Is that normal or not? Yeah, that's normal. Pulse rate is 110. Is that normal?
No.
It's a little bit high. It's a bit tachycardic. BP is 170. Is that normal? Potentially. JVP is 5 centimeters. Is that normal? No. What does that indicate?
Right heart.
Potentially right heart failure. So we'll just write that down. Maybe fluid overload. Fluid overload. Maybe venous congestion. We don't know, but at the very least, it's not normal. Okay. On cardiac, also, he has an added heart sound after. So he has a systolic murmur at the apex. What's at the apex? So what would cause a systolic murmur? As in, like, what abnormality is systolic? Yeah, so he potentially has some mitral regurg. Potentially. Okay. All right. Do you think he has mitral prolapse? Yeah, potentially. So we'll question mark there. Rheumatic fever.
Oh, I didn't say that.
Do you think he has rheumatic fever?
No, he's
No.
not quite febrile.
So remember, for rheumatic fever,
And he doesn't have the other criteria.
so what are the criteria?
So it's Jones criteria.
Yeah.
So migratory polyarthritis.
So there's a mnemonic for Jones criteria, and the mnemonic is actually Jones criteria. All right. So J is for joints.
Yep.
So your migrated polyarthritis. O is for
Ocarditis. So all three layers of the heart.
yeah, obvious. Something I think it's like obvious carditis or something like that. Yeah. N.
N is the neurological symptoms of chorea.
Yeah.
E is erythema. I want to say multiform.
Yeah.
Marginal.
Marginal, okay.
S.
S is the subcutaneous nodules.
Subcutaneous. Beautiful. So this is your major criteria, right? So he doesn't have any of that. So it's very unlikely that he's going to have acute rheumatic fever. And then criteria. So these are the minor criteria. It's amazing how well these things work. So this is like CRP, and this is like temperature, and this is like, is it? Oh yeah, ESR. This might be like renal function, and I can't remember the rest, but it works really well. So he doesn't.
Sorry, I thought there was only like 3 minor criteria.
No, they use
quite
all.
a bit.
Yeah, there's quite a few. Okay, so and I think you need like maybe more than 2 major, or you need more than 5 minor, something of that nature. But he doesn't have any of that.
I think it's so actual culture or of the bacteria, or you have the ASOT titer. Then it's 2 major or 1 major, 2 minor. I'm not sure if you can base
I see.
it just on the minor.
Okay, perfect. Thanks for that.
One before you can use the minor.
Okay, so we can rule that out. Okay, bacterial endocarditis. Well, so what criteria do we use for that? Duke's criteria. Okay, Duke's criteria. So in this case, he doesn't have fever. I can't remember Duke's criteria exactly, but he doesn't have fever. He doesn't have other things that would suggest bacterial endocarditis. So not that.
I mean, he has a new adenovirus, so it's possible.
Okay, but how we consider the first 2? We need to think what's the most likely diagnosis. So here, the most likely diagnosis is one of the top 2. So pericarditis or myocarditis. What are they? What's pericarditis? Yes, what is a pericardium?
That was a given. But that would be more like, isn't that the like chest pain, like on position as well?
Yeah.
And then more thyroid chest pain?
Well, the thing is, well, you don't really have enough medical history, or you don't have enough on history to know whether he has positionally dependent chest pain or not. But the thing is, he has, so it's first viral, okay, which is 1. That's very good. He has chest pain. He has potentially a pericardial friction murmur. So he has maybe a friction, which also can sound like a systolic murmur. Okay, so the thing is, having chest pain after a virus is very suggestive of pericarditis. So how would we differentiate it from myocarditis?
There shouldn't be any changed heart function in pericarditis.
Yes, exactly. So in this case, is there anything that suggests that he might have had a change to heart function?
Well, he now has sort of murmur, and he's got an elevated JVP.
Yeah, so he has an elevated JVP, which suggests potentially does he have muscle involvement. So given that, our best diagnosis is myocarditis. Now it is a little bit difficult to actually come to that conclusion because myocarditis is a rare complication of pericarditis. But in this situation where he potentially has symptoms of heart failure, myocarditis is reasonable. So if somebody is presenting to you like this, and the other thing is, the other thing that suggests is myocarditis, that can cause mitral regurg because the leaflets are unable to close properly, which also might explain his murmur. But like I said, pericarditis can also have a murmur just from a pericardial friction rub. So the other things I would look for is tachycardia, which he potentially has, a gallop rhythm, any other symptoms of heart failure, that would make myocarditis very likely. But still in this question is probably the best diagnosis. So if somebody comes into you with this kind of picture, and pretend you're in an OSCE, you're the intern, what do you need to do? So we'll pretend you've done all of your doctor's ABCD. Now I just want the definitive things that you need to do. Somebody's coming with chest pain. Number 1, ECG, sure. ECG, what?
Analgesia?
Sure, analgesia, but what's most important? What do you need to do? What must you do? No, What blood test do you need to do? Troponin. You need to do troponin, okay? So now you've done troponin, that's all normal. What else do you need to do? What imaging do you need to do? That you can do at the bedside in the ED department?
Ultrasound.
What kind of ultrasound? An echo. So you want to do an echocardiogram. So then why are we doing an echocardiogram?
Check the heart ejection function.
So the reason, the actual reason why we're doing an echocardiogram is we're checking for pericardial effusion, which is again another rare complication of pericarditis, and you need to repeat that after another 6 weeks because they can have a pericardial effusion that can cause much more damage. So that's another important thing to do. ECG will show you whether they have any acute coronary syndrome, and what management do we need to give them? Do we need to keep them in the hospital? If it's pericarditis, definitely not. So what would we give them in that situation? Colchicine is one. And how long would we give them colchicine for? Do you know why we give it to them? Colchicine isn't a really normal medication that we give many people. So colchicine prevents recurrent pericarditis, and usually we give it for a period of around 6 weeks. But we don't always give it. The first line management for pericarditis is NSAIDs. So because it's an inflammatory condition, we give NSAIDs. Now, you don't always give it to everyone, but what's another good medication you could consider giving to someone who's being started on the NSAIDs? PPI. So because it can cause some gastritis, it can cause some inflammation in the tummy, you definitely want to consider whether you want to give them a PPI or not. And I just want to reiterate this. Pretend you're in an OSCE. Even though you think this man has pericarditis, you always need to consider your red flags. So you need to consider whether they have had an acute coronary syndrome, a PE, pneumonia, pneumothorax. You need to rule out all of those. Okay. And you know what's interesting about this is 98% of people will complain of pleuritic chest pain when they have pericarditis, and a lot of people will tell you that they have pain in the night. They'll have trouble sleeping, and the reason for that is exactly as you said, Jess, is positionally dependent. Now, the reason that is interesting is because I actually had pericarditis last year, and I presented so much like that. I had pain at nighttime. I had a systolic murmur. My GP sent me to the ED. They did an echocardiogram, and I was sent home on NSAIDs. So it's very interesting at how closely it actually followed all of those signs and symptoms. How are you going, boys? Okay. An old lady, she has sudden loss of vision. Is that concerning? Absolutely. Okay, 1 hour ago. Is 1 hour dangerous yet? Not yet. Yeah, okay. So she's had pain in her jaw muscles, when chewing, thick and tender superficial temporal artery. What does she have? Temporal artery. So what do we need to do? We need to commence steroids straight away. Okay. Now, what causes her to have temporal arteritis usually? What's the umbrella term? Giant cell arteritis, right? GCA. So what's GCA? It's a vasculitis. Okay, so it's a vasculitis usually affecting our medium to small vessel. Okay, medium to small vessels, and that causes inflammation there. And why is she having this loss of vision? What vessels are being affected that cause her to lose vision? Yes, the ophthalmic artery. Okay. So high dose steroid straight away has been shown to decrease the symptoms pretty well. So ophthalmic artery. And is there anything else need to go? Okay, right. And the actual pathology in this case is something called arteritic anterior ischemic optic neuropathy. Have you guys heard of that? AAION?
Yes.
If you've done the eye modules in GP land, you would have come across that term. So arteritic anterior ischemic optic neuropathy. All right. So in this case, you probably give her, in the GP setting, you could probably only give her oral steroids before you send her over. But ideally, you'd want to give her like IV methylpred for a quick onset of action. Then you need to refer to the ED immediately. So imagine you're in an OSCE. What you'd say is, you'd explain the diagnosis to the patient. You explain how urgent and how life-threatening it is. You tell them we need to give you steroids right now. You'd make sure that they don't have any kind of allergy to steroids or something that contraindicates it. And then you'd say, I'll call the ED ahead of time, or I'll get my nurse to call ED ahead of time. You might do an eye examination, etc., etc. And then you call the ambulance. All right. All right, so this is what we're going to do. So we're going to talk about red eye.
Is this a paper question or is it just random question? Paper?
So a lot of these, not all of them, but a lot of these questions are continuation of paper 5 from what we did last week. And then there's some new ones. Okay. All right. So we're going to do an anatomical approach to red eye. At the very least, we're going to try. So the topic here is a unilateral red eye, or a red eye in general. All right. So I'm going to choose purple. Okay. So cornea. Okay, before we do that, actually, there's 3 layers of the eye. The eye is like an onion, much like how Shrek is an onion. Okay, so the eye has 3 layers, and you can see them here. Okay, so 1 here, 2nd, and 3rd. So they're broken down into 3 parts. So this is the fibrous layer. This is the vascular layer. And this one is the nervous layer. So the fibrous layer is made up of 3 parts, and we call those parts the uveal tract. The reason I'm telling you that is because it will help you to understand uveitis. So the fibrous layer is made up of, the 2nd layer. So fibrous layer is made up of the cornea plus the sclera. So the reason it's called the fibrous layer is because it's hard. For example, the sclera is the white part of your eye, so that protects your eye. The vascular layer is made up of the choroid, okay, which is this little section here running all the way. So that's your choroid. The reason it's called the vascular layer is because that provides the blood supply to the retina. It's very vascular. The choroid, does anybody else know what's in here? So if you look at here, it's continuous with this structure. This is the ciliary body. And then the ciliary body is continuous with this, which is the retina. So those 3 structures, the iris. Iris. Okay, then the nervous layer is your retina. So 3 layers to your eye. All right. So let's begin with the fibrous layer, so the outer layer of the eye. We have 2 main structures. We have the cornea here, and we have the sclera, which is here, so the white part of your eye. And on top of that layer, what is that? The conjunctiva. So that's a clear layer that you can't see. And what you can see on this diagram is this is how the conjunctiva runs. So the conjunctiva runs under the eyelid, then it folds over, and it continues up until this point, until the cornea. So it covers the sclera. So that's why you get a diffusely red eye when you get something like conjunctivitis. So that's our first condition. So what affects our conjunctiva is conjunctivitis. So conjunctivitis. And that's broken down into 3 categories. What are they? Viral, bacterial, and allergic. And then the treatment for each of that differs significantly. So for viral, what would we give them? We'd give them eye drops, okay, because they can have an irritated and dry eye. So just normal eye drops, just to keep it lubricated. If it was bacterial, yes, chloramphenicol. And allergic, so you give them like antihistamines. So I can't remember exactly what they give them, but some things are things like sodium chromoglycate is one I've come across before, but there's a few other things that you should check up on ETG. Okay, one thing we didn't talk about, how about the eyelid? So what kind of conditions affect the eyelid? Okay, so there's a few conditions, so we'll talk about the eyelid now. So I've heard blepharitis. What else is there? And we'll say sty. Okay. So blepharitis. What is blepharitis? So that means it's associated with a condition in particular. No, not psoriasis. Sebderm. Okay, because that can cause, like you said, crusty skin. So sebderm, and this is actually a blockage of your meibomian glands. Okay. Well, seborrheic dermatitis is a risk factor for developing blepharitis. So it's a blockage. Okay. And that's different to sty. What is sty? This is an infection. So this is usually an infection with Staph aureus. So Staph aureus infection, also potentially of the meibomian gland. Okay. And because this is just a blockage, it's typically not painful. It might cause discomfort Whereas because this is inflammation, this one is painful. Okay, all right. So again, so let's take another step back. So before we even talk about intraocular pathology, we have to talk about extraocular pathology. So what kind of extraocular pathologies that can cause a red eye are important? Cellulitis. So there's two types. What are they? Periorbital and preseptal. So what's the difference between them? And why is it important?
Like it's just worse if it's.
So the thing is that something like periorbital cellulitis has the potential to cause inflammation of your orbital tissue. That can cause impingement on the optic nerve and of the retinal tissue, and that can cause blindness. So that is why that's a red flag condition that you must identify immediately. So in the absence of extraocular pathology, we then move on to look at the eye. So eyelids, so we look for any blepharitis, we look for any stye, then we look for any conjunctivitis. So we've talked about viral, bacterial, and allergic. So now we get to the cornea. So what kind of things affect the cornea? Yeah, foreign body. So we're talking about the cornea now. So foreign body is one. What else affects the cornea? Okay, yeah, trachoma. What else? So I'll put that here. I'll put abrasion here. But you can have abrasion from many things. What else? Yes, herpes. What does that cause? Keratitis. Okay. And what type of ulcer does it cause? Dendritic ulcer. Okay. So all of these are very important things to identify that affects this layer of your eye. Now, importantly, the cornea is a highly innervated structure. So it's quite painful if you get something that affects your cornea. All right. So for a foreign body, what is important that we need to do when we see them in the ED? Not an X-ray. We need to, well, what's the first thing that we can do? Fluorescein, right? So we can do a fluorescein. And we usually do that for all of them. So for HSV keratitis, we'd also do a fluorescein, okay? And then we do a slit lamp. So what that's going to allow us to see is if there's any areas in which the fluorescein is up, if there's an uptake. And that allows us to identify if there's been any abrasions, if there's any foreign bodies in that location, if there's an ulcer. Because if there is an ulcer, then we need to treat that immediately because that can also cause blindness. The reason for that is damage to the cornea can cause opacification, which can cause damage to your vision in the long term, okay? Trachoma is quite rare, but it's very common in our ATSI populations. All right.
What's fluorescein? Is that just like
It's just a dye. It's just a dye that you put into the eye, and then you use the blue light. So a lot of people call it Wood's light. So it's just like an ultraviolet looking light. Then you use the slit lamp, and that causes that dye to light up, and you can see anywhere where it's uptake. So usually what I'm trying to say is it looks green when you put the blue light on it. It's orange in nature, but when you put the light, it's green. And normally you won't shine anywhere in the eyes except like around the edges where it's kind of accumulated. But if there is a little abrasion in the eye, if there's an ulcer, the dye collects in that area and it brightly lights up. So that's what you're trying to look for. I'll have some pictures later. All right, cornea. All right, so if just going back to eyelid for a second, so if we did have blockage of the meibomian glands, if we did have a stye, if we did have blepharitis, what would the management be?
Like
Warm compress, eyelid hygiene. So it's just simple conservative management for blepharitis, and you'd also give artificial tears because it can cause some discomfort. And if it was a stye, then you consider whether you need to give any antibiotics or not. All right. Okay. So the reason that we'd give antibiotics in something like a stye is if there was any associated conjunctivitis. Otherwise, it's also conservative management. All right. So we talked about cornea. So we've talked about cornea. We've eyelid hygiene and artificial tears just for symptomatic relief. So we talked about cornea. We've talked about conjunctiva. We've talked about the eyelid. So now we need to talk about the iris. Okay.
Stye the infected, and then chalazion the blockage? Am I remembering?
Might be.
Stye is the
Stye is the infection.
Pimple on the
Yeah.
eyelid, right? And chalazion is like the blockage of the meibomian gland.
And that's also the meibomian.
Yeah, but it's like
cyst,
aseptic,
yeah.
so it's like
Yeah.
there's no infection.
Okay.
It's supposed to say chalazion and blepharitis.
Blepharitis is like dry skin of the eyelid.
So not a major design obstruction.
Is it not?
I don't think so. It's like the flick.
Okay, my
Well, I
bad.
just trusted you.
It must be Clasian then. I apologize. My bad. Thank you, son, for bringing that up.
So then blepharitis is literally just cervical sides of the eye.
On the eyelid, yeah.
Okay.
It wasn't dry.
All right. My apologies for that. All right. All right. So now let's talk about, what should we talk about next? The sclera. Okay. So cornea is this section. So the sclera is this section. So
Yeah, sorry, chalazions the blocked oil gland.
all right. My bad. All right. So sclera is this location here, and what can happen there? Scleritis. And what's the other condition? Okay. So what's the difference?
Episclera is just like a segment.
Exactly.
Whereas
So
sclerosis is like the whole shebang.
So localized versus diffuse red injected eyes, and it's usually a very, very red eye. The reason for that is because it's superficial, so we're affecting the sclera. So the vessels are very, very evident, and sometimes you can actually see the vessels have become inflamed and quite red. So that's how you differentiate scleritis from something else that causes a red eye. And in that situation, what would you give? What would you be your management? So if I have episcleritis, the management is NSAIDs, and then just artificial tears. So tears again, so the tears are just symptomatic relief. Okay, so now let's move on to the anterior chamber. So we talked about cornea.
Right, so is scleritis an infection or?
It's an inflammatory condition associated with like autoimmune
Yeah.
diseases.
So a lot of these are actually associated with autoimmune disease. We'll talk about anterior chamber now. So we'll talk about iris. So the iris, what condition do you get? Iritis, okay? So what's another name that people use for iritis? Anterior uveitis, okay. So anterior uveitis, so uveitis is just an umbrella term. And notice that it says anterior in the name. The reason for that is because you can have intermediate and you can also have posterior uveitis. So intermediate is inflammation of the vitreous tissue, okay? Anterior is inflammation of your anterior chamber here. So inflammation of your iris, your ciliary body in some situations, and of the aqueous humor that is in that location. And then posterior is inflammation of your choroid and your retina, which is called chorioretinitis. Okay, so chorioretinitis, you know, from CMV and toxoplasmosis. You know, there's childhood neonatal conditions, fetal conditions, so fetal infections that can cause chorioretinitis. So chorioretinitis is a type of uveitis. So remember, uveitis is just referring to the uveal tract. Anything in that tract can become inflamed. So the anterior uveitis is referring to the fact that a uveal tract is made up, like we talked about, of the iris, of the choroid, and of the ciliary body. Okay, so for iritis, what happens is that you have inflammation of the iris plus the anterior chamber, and anterior uveitis also includes iridocyclitis, which is inflammation of the iris plus the, not the choroid, and the ciliary body. So that's iridocyclitis. So that's the difference between the two. So the reason that we use the terms interchangeably is because iritis is included within anterior uveitis. So what is a common cause of anterior uveitis? Or what do we need to look for? So anterior uveitis is associated with what? Exactly, so seronegative disease. So in that case, usually we need to do our full room antibody investigation. So we need to look for things like ANCSPON. So ankylosing spondylitis is highly associated with anterior uveitis. So if you remember, if we go down our body for somebody who has ANCSPON, there's 6 common complications that they can get. So starting at the top, we can get anterior uveitis. Then going down to the neck, we can get axial instability. Then if we go down to the level of the heart, and then we go down to the level of the lungs. So aortic regurg for those at home, lungs, apical lung fibrosis down into the tummy. We can get autoimmune bowel disease, so IBD, and then down all the way down into the legs. Achilles tendonitis. Okay, so seronegative is important because most of these are HLA-B27 associated conditions. So you need to look for all those conditions for somebody who's presenting with anterior uveitis. So what would anterior uveitis look like? So if you know it's inflammation of the iris, like I've told you, and it's inflammation of this little section here. So how would it actually look like on the examination? I mean, the reason I'm asking is like it's different from the cornea, right? The cornea is this whole covering, so all of that would go red, right? But you don't have the cornea affected in something like anterior uveitis. So what would you see on examination? Can you imagine?
I think you can see things floating if you translate it.
Yeah, so potentially. So very, very common to see in anterior uveitis is something called hyperion, which is when you have your white cells that are located within the anterior chamber. So you can see that it's a very clear sort of like what you would call like a fluid, a liquid level, you know, what you see in the lungs. It sort of looks like that. I'm not sure if I have a picture or not. And the other thing is with repeated inflammation, and I'm not 100% sure what the actual cause is, but you can have something called anterior synechiae. Okay, have you guys heard of that term, synechiae? So it's inflammation. So synechiae, it causes abnormalities of the pupil. Remember, the pupil is just this section here. So the pupil isn't actually a structure within itself. So pupillary abnormalities occur because we have some kind of iris abnormalities. So anterior synechiae is when you have these sort of adhesions or this inflammation that's occurring in the front of the eye that causes the lens, usually the lens for anterior uveitis to distort, which is why you see pupillary abnormalities in anterior uveitis. Does that make sense? So anterior uveitis is still included in the red eye. What's the reason for that? What is the redness? Well, the things you can get ciliary flush, which causes a redness around that area around the iris. So that's something that you can see. So you get ciliary flush, which is why it's included in red eye conditions. And for many other reasons, I mean, there's many things that we didn't talk about. Inflammatory response is going to cause a red eye anyway, or there might be something else going on. But at the very least, you understand some of the presenting features. Oh, okay, right. Another cool, just a cool add-on. So uveitis is actually Greek for grape. So the reason for that is, one, because on gross pathology, the choroid has a sort of wrinkled appearance that sort of looks like grapes. And we're referring to like red grapes here. And the choroid is also highly pigmented. So it's sort of like melanin pigmentation. The reason for that is it prevents light. It causes, what would a dark light do? It absorb the light, right? So it helps the light to focus down onto the retina. So those are the two functions of the choroid. One is vascular. The second is to absorb all of that fragmented light. I'm not 100% sure that's true, but it's got to do with the light, the fact that it's pigmented. All right, let me see if there's anything else I need to talk about. Oh, okay. So I know there's always these little add-ons, but for uveitis, anterior uveitis makes up 90% of all of the presentations for uveitis, which is why we use iritis and uveitis interchangeably. But at least you understand that uveitis is an umbrella term, okay? Okay, cool. All right, how would we manage it, uveitis? Steroids, so corticosteroids. All right, let me just see if there's anything else I need to talk about. I think that's good. All that makes sense. Any questions? So that's just, I mean, I hope it helps to understand at least somewhat causes of red eye and why we get it. All right. Oh, glaucoma. So that's the reason I put it on this slide is because it's such an important condition that we need to talk about that can cause a red eye as well. So what is glaucoma? What is the definition? Anybody? Whoa. Does anybody know what the definition of glaucoma is? Okay, so all of that is reasonable, but the actual definition of glaucoma is, well, it depends on what type we talk about. But in general, let's say we're talking about open angle chronic glaucoma. So it's a progressive degeneration. So progressive degeneration of the optic nerve. So that's what ON stands for, optic nerve. And that can cause visual field defects. So that is a general wide kind of definition that we use for glaucoma. Okay. Now, of course, it depends on the presentation, but that definition can change. All right. So glaucoma, this word actually came from the Greek word for called glucosis. Okay. And glucosis, this actually means a cloudiness, so like a green sort of blue cloudiness. Interestingly, that's something that we look for in the examination when we do for glaucoma. So that's something that they noticed back in the day when they defined the term, and that refers to the cloudiness, and you can still see that on the examination. So that's one of the features that we look for. Okay. All right, so from that out, so there's two main types of glaucoma that we need to talk about. What are they? Anyone? Okay, so primary open angle. Which one's more common? Yeah, so this causes 90%. So this is one of the leading causes of blindness worldwide is glaucoma. So not everybody's going to present acutely. So it's a primary open angle glaucoma. All right. Well, both of them can happen in old age, but I guess it's the pathophysiology and how they present that differentiates between the two. So imagine this sort of just like a sink. So for a sink, something like glaucoma is going to close that sink really quickly. Whereas for chronic, it's just that sink, the drainage port is progressively getting smaller and smaller. So this is sort of a clogging of those drainage canals. So usually with the pathophysiology, they don't know 100% sure what it is, but it's sclerosis of the intraocular of vessels in Schlemm's canal. Okay, so if you guys remember Schlemm's canal, that is what allows the drainage from this section in the anterior chamber, and it allows it to be reabsorbed. So somewhere in that nature. So Schlemm's canal is somewhere here, and that allows the drainage. So Schlemm's canal becomes blocked. So how these people present is insidiously. So it's usually something that's not picked up, which is why we need to do screening for it. So usually we do screening after somebody's over the age of 50, if they have other risk factors, and if they're higher risk, then we do screening more regularly. But it presents insidiously, and it uses a visual field defect, so visual loss. So usually you lose your peripheral vision first, and then you sort of get tunnel visioning. You guys heard of that? You get tunnel visioning. So you get tunnel vision. All right. So the kind of people that we'd want to, so because it presents insidiously, the people that we want to screen are people who are more than 50 years old, okay? Or somebody who's more than 40 years old, and if they have other associated risk factors. So for example, if they have diabetes mellitus, if they have eye problems, if they have something like myopia, if they're on long-term steroids, if they always get headaches. So those are the kind of reasons why we want to screen them. So screening is usually done every 5 to 10 years, and it might be done more regularly if they have more risk factors. All right. So if somebody is determined to have glaucoma, let's say you refer them to the ophthalmologist, then the ophthalmologist does things like goniometry, if they do tonometry. So they determine that the patient has high intraocular pressure. What medications would we give them? So how would we treat someone with primary open angle glaucoma? Yes, okay. So a PG analog. And what medication is that? I mean, I guess you need to know at least one. Lantoprost. So lantoprost is the one that's commonly used, all right? But the definitive management is opening up that drainage port. So because that drainage port is blocked, we make a new one. And how do we make a new one? Through laser, right? So laser therapy. So laser is your definitive therapy. So usually laser trabeculotomy. I can't put it all there. All right. Another medication that we might use is timolol. All right. But we wouldn't be able to use timolol if somebody has heart block because it's a beta blocker, right? And the reason that we might not use lantoprost is because this can cause a very characteristic side effect, which is, so it causes brown pigmentation. So brown pigment of your iris. So in your iris, it causes little brown deposits, which is one reason why somebody might stop being on a prostaglandin analog.
Did it actually make anything bad?
Sorry?
Like if the brown pigment is something bad?
I'm not 100% sure. I'm not sure. Okay. All right. So that's open angle. Now there's a lot to talk about for glaucoma, but I recommend that you go look it up. So now let's talk about acute angle closure glaucoma. So this is the most serious one. So what happens here is, So what happens here is this angle, so the iridocorneal angle becomes blocked for whatever reason. And then that causes an acute blockage of Schlemm's canal. So let's say you had a kitchen sink. If you block that drain, then all of the water starts to overflow. So that causes an increase in the intraocular pressure. So how would we diagnose a high OOP? You'd have a hazy cornea. So remember, going back to the definition of the etymology of glaucoma is cloudiness, so blue-grayish cloudiness. So you have a hazy cornea. They might have a shallow chamber, etc., etc. Now, on exam questions, the classical stem was an elderly lady who started to get this pain in her eye when she was watching TV at nighttime. Why is that important? Why is the nighttime important? What happens to the eyes at night? It dilates, right? So it blocks them more. So a risk factor for getting glaucoma is at nighttime when you have dilation of your pupils that can precipitate an acute blockage of that angle. So that's why nighttime is important, and why in the GP setting, your management is, do you keep them in the dark room? No. So you don't keep them. So management in the GP setting is one. So how do we constrict the eye? What medication would we use? Pilocarpine. Okay. In the GP setting, what might we be able to do if we had the medications? So in the acute setting, we can use things like acetazolamide, okay, which is a carbonic anhydrase inhibitor, okay. What else do we need to do? We need to give them urgent referral to ED. So imagine if we were in the OSCE setting, we'd say, we'll call ahead. So we'll call ahead. We want to give them symptomatic relief and get them an urgent ophthalmology referral. So you need the ophthalmologist to see them as soon as possible. Okay. All right. That'll do. So this little table here. So I was planning to do this year, but I just ran out of energy and or time. So this is one thing that I started doing last year, which is to help me prepare for my OSCEs. So this is my version of a 10-step management plan. So 10 steps. So this question cluster is just something that I introduced to you guys in third year. So making that set of questions for every differential diagnosis that you have and being able to ask them. And then this is the 10-step management plan, is education and management. So I can't remember my 10 steps, but I'm pretty sure all of them are here. So when you go to educate the patient, you need to tell them what the diagnosis is. You need to tell them the differential. So what that means is you need to explain to the patient how you came to the diagnosis and why it isn't another differential. So you need to explain to them, for example, why this isn't something like uveitis or some other kind of red eye condition. You need to normalize the diagnosis. So what that means is you need to tell them about the epidemiology. You need to tell them that they're not alone, that this is a very common condition that affects a lot of people and that there's lots of support available. You need to tell them what symptoms they have that made you certain that was the diagnosis, what kind of complications they can expect, and what their prognosis is. So when you're educating the patient, those are the things that you need to talk about. So we'll just quickly go through this. So I put this slide in just for your reference. You can go back and read it properly. But at least I found this was a good way to prepare for my OSCEs. So explain the diagnosis. So it's an urgent but reversible condition where the drainage canal becomes blocked. So you could use the kitchen sink example that I gave you, but you can use any example that you want to, okay? And in this case, the glaucoma isn't really a necessary condition that you need to explain differentials. So if they came with a red eye, that definitely wasn't glaucoma, then you would go on to explain differentials. So we've done diagnosis. We'll cross that out for the moment. The normalized, so it's a common condition affecting nearly 45 million people worldwide. So that's something that you need to say in your OSCEs. You need to normalize it to the patient so they don't feel isolated. For example, something like breast cancer. So somebody comes with a breast cancer, it's the end of the world diagnosis for the patient. So you need to do something that helps them to make them feel better. Okay, and then we talk about symptoms. So we talk about blindness somewhere. So yeah, blindness. And we want to talk about complications, which is blindness. So we want to treat as soon as possible. And then prognosis. The prognosis is very good. So you need to mention all of those when you try to educate the patient. And as you can see from that little paragraph, it doesn't actually take that long. So as long as you hit all of those points, you should be golden. All right. Then we need to talk about management. So all of this is in Murtaugh's 10 commandments, but I've just put it in this table format for you. So refer you to hospital straight away. So immediately, what do we need to do? We need to refer you. So referral is just to remind you that you always need to talk about referral in any single OSCE station that you do. So you don't need to state it, but you need to think about it. do we need to refer this patient anywhere? So for example, if somebody comes in with appendicitis, you need to say in your OSCE station, I need to call the gastro team and get them to come and review the patient, all right? So immediately you need to get them to hospital, where you'll be assessed by the ophthalmologist, and we'll get the practice nurse to phone ahead. So I've just told the patient immediately what we're going to do. And then before we go to the hospital, we're going to give you pilocarpine, then acetazolamide. And this is really the most important part, is a lot of people ask me, like Taha, in the OSCE setting, we need to pretend to be the GPs or whatever. So how do we then use that to explain what they're going to do in hospital? You just specifically communicate that. You tell the patient what you will expect to happen in hospital. So in this case, they're going to do some tests and they're going to make sure that that it doesn't happen again. And then I didn't mention it here, but ongoing, what you need to tell the patient is they need to have regular ophthalmology follow-up after that. Okay? Then preventative is what you do in every station. So do whatever you like, but this is a good way to, or at least I found a good way to prepare for your OSCEs. So if we're in an explanation session or something of that nature, this is at least a good way to approach it.
In an emergency one like this, how do you do prevention, not just tackling that?
See, that is high. Well, I guess it depends on what kind of station that you're in. But in this case, prevention could also coincide with long-term management. So it's not like, so until the ambulance arrives, what are you going to do with the patient? They're just going to sit in silence. So you can tell them that this requires, yeah, well, you tell them like risk factors for this condition includes things like smoking and diabetes and the such. So because of that, once you're out of the emergency department and once this condition is acutely managed, I want to make sure that you come back to our practice so that we can talk about your smoking practices, that we can talk about your diabetes and cholesterol management, so that we can make sure that you don't have any other problems in the future. So you can easily incorporate it into your station. It just depends on how you communicate and how you actually say it. So the way that you say it is like I just said, you tell them after you're acutely managed, come back to the GP and this is what we're going to do. Does that make sense? All right, I've said this point and I'm going to say it again. The way to differentiate yourself in an OSCE, because everybody has good knowledge, is your communication skills, okay? All right, so just going through some pictures of acute red eye. So this shows you the difference between orbital and preseptal cellulitis, okay? So you can understand now by looking at that picture why orbital cellulitis is a medical emergency. 11% of people who have orbital cellulitis will then go on to be blind if it's not managed. So that's why it's a red flag condition, right? So what is the main differentiating feature? Yeah, so pain with eye movement because we have inflammation of the orbital tissues, okay? So typically what the patient would have, they'd have some fever, they'd have some erythema around the eye, tenderness, edema, all of those things. All right. So yeah, we'll keep it there. All right. So this is conjunctivitis. So this table I got from one of the RSCGP articles. Remember, I always tell you, always look up guidelines. So this gives you a really good question cluster that you can use in your OSCEs. So this is just an example of a viral cellulitis. So what you notice is this watery discharge. The patient would have gritty eyelids, and you notice this redness or this diffuse redness that is all around the conjunctiva, and it's relatively painless. And it's painless because the conjunctiva doesn't have a good vascular supply. It would irritate the patient, but it wouldn't be necessarily painful. Okay. All right. So now we go into foreign body. So there's a lot of different pictures here. So this one, what is this? Okay. So this is what I was talking about before when I talk about fluorescein. So fluorescein normally, you can see is collecting here. You normally just like collect up in here at the eyelids where you naturally collect. But normally you wouldn't see fluorescein in other parts of the eyelid unless you have some kind of abrasion or trauma or some kind of disruption to the cornea, because the cornea doesn't regenerate. So if it has trauma, it's going to stay there for a long time. And the fluorescein, it goes in that area. So we call this like a lightning shape appearance because it sort of looks like a lightning bolt. So dendritic ulcer is important. That needs immediate referral, and it needs management. So it needs a cyclovir pretty urgently. And you don't give steroids. So does anybody know why we don't give steroids? So you don't give steroids because it increases a small risk of increasing the risk of perforation. I'm not exactly sure what's perforating. I just know that it increases the risk of something perforating. Okay, or yeah, at the very least, it's bad for HSV keratitis. So that's one. So what's this?
Is the acyclovir topical?
I'm not 100% sure. I imagine it would be, but don't quote me on it. Don't quote me on many of the things I say. Okay. Does anybody know? Look how these look. They're very vertical, right?
It looks like the eyelash.
Eyelash. So why would the eyelash be causing abrasions to the cornea? Entropion. Okay, so this is entropion. So entropion is common in which populations? Yes, so it's common in ATI populations. I don't know why. I think it might be something to do with chlamydia. Yeah, I think it's related to trachoma. So you get entropion in that situations, and you can see it very clearly. You can see these little linear marks. Okay, and then this one is a foreign body. Okay, so you'd use your small gauge needle to try and pick that out of the cornea. Right, and in that situation, as Roland said before, you definitely need to do an X-ray to see if there's any foreign bodies located within the orbit itself. Okay, and another thing, just out of your interest, if any of you guys have ever had a slit lamp tutorial on how to actually use it, do you guys note how sometimes they look at the eye on an angle? So the reason they do that is the refraction of the light you get when you put it on an angle allows you to see everything in the anterior chamber. So by looking at it on an angle, you can see if that foreign body has penetrated at all or not. So that's why they look at it on an angle. That's just for your interest. So uveitis. So what do we notice here, first of all? Well, you can't see synechiae, the pupillary abnormality, and now you understand. Well, I hope you understand why they get it. Okay, do you guys understand why they get it now? Yeah, because we have that synechiae. So this one, so this is the redness that we're talking about. So this is called that's a ciliary flush. Okay, so that can cause the mild redness. And another, you can actually see it here. I didn't think I had one. What's that? Yes, the air fluid level. Hyperion. It's not actually an air fluid level. I just want to make sure that you know that. I just called it that. So that's a hyperion. You can also get a hyphema, which I believe is red blood cells, but I'm not 100% sure. But hyperion is very, very related to uveitis. Okay. I'm just seeing if there's anything else I need to talk about. Also, just other symptoms. So we have the redness with the flush, the photophobia, pain, the pupil, the hyperion. So we need to give them steroids. And apparently mydriatic, so things that dilate the pupil. Mydriatic. So mydriatic agents, those can help break down some of those synechiae. So sometimes that can help. What's this? Okay, and so you need to know all of these symptoms. So redness, dilated pupil, and cloudy. These are your three cardinal features of glaucoma. So you need to be able to identify it. Okay, and these are just here for your reference. A good question cluster. What would this be? Scleritis. So what I was talking about before, remember our eye diagram? Our sclera was this section on the top where all the vessels are. And what you notice here is you can very clearly see the vessels. So that allows you to differentiate scleritis from other causes of a red eye because you'll be able to see those vessels quite clearly. And this one would be episcleritis. Okay, so episcleritis is usually self-limiting, which is why we don't need any specific therapy other than things like NSAIDs or artificial tears. Okay, so we spent a long time on that. So now we're back to our normal questions. Right. Now, just because I want you guys to get out at a normal time today, I'm going to go through this a bit quicker. So old man, 3 months of gradually worsening discomfort in shoulders, back, hips, and thighs. Before I go on, these are larger joints, right? They're not small joints. They're large joints of your body. Shoulders, hips, knees and toes. So these are large joints of your body, okay? Sore and stiff. Mornings are bad. So you have some morning stiffness. Morning stiffness can be anything. Yeah, well, it could be degenerative or inflammatory. He's lost some weight. Loss of weight. So his range of he has decreased range of movement by discomfort. Okay, but his power is normal. So the fact is, well, he says distal power, right? But what condition would you expect the power to be abnormal? So, what rheumatological condition? Polymyositis, okay? So maybe we'll just go through this first. So what would we do a muscle biopsy for? So polymyositis. So polymyositis is a weakness. Now in this question, does he have weakness? No, he doesn't. So his range of motion is limited by discomfort probably from the stiffness. So he doesn't actually have proximal muscle weakness. So polymyositis is a myositic condition, so inflammation of the muscle, poly because it affects multiple muscles. So if this question said that he was having range of movement limited by pain rather than discomfort, then I think muscle biopsy would be the best answer. But it's discomfort, not a pain. So that's why muscle biopsy is not the best answer. What would we do MRI cervical spine for? Well, potentially, but but spondylosis, okay. So any kind of spondyloarthropathy, arthropathy, you might do a cervical spine. What would we do a bone biopsy for? Bone scan. So OA potentially, so any kind of degenerative condition. Anti-CCP, rheumatoid. Okay, could this be rheumatoid? Absolutely, definitely, 100% it could be rheumatoid, but what feature in the stem tells you that it's not? He has no evidence of it. So they covered themselves well there, didn't they? So it's not going to be that. So the last one is CRP. So what is the diagnosis here? PMR. So he has polymyalgia rheumatica, which is characterized by stiffness. Polymyositis is characterized by pain, and dermatomyositis is characterized by rash. Okay, so CRP is not necessarily the best test for PMR. ESR is probably the best test, but CRP is close enough. Okay. All right. 23. So young female. She's unlikely to have any pathological conditions. She's had bleeding from her gums. Before we even go on, bleeding from her gums, what are differentials? Scurvy.
I was going to say scurvy, but I was like, that's ridiculous.
That's ridiculous, yes. What are better differentials? Yes, leukemia, but what is the pathology in leukemia that's causing you to bleed? Thrombocytopenia, okay. Decreased platelets. Okay. So when brushing your teeth, some spontaneous bruising, non-specific illness, fevers, myalgia. So she's had a virus. Seems like everybody has had a virus. So she takes an OCP. She has some petechial bruising on her trunk and limbs, no splenomegaly, all lymphadenopathy. What would that help you to rule out? Any hematological malignancy, okay? So most likely diagnosed aplastic anemia, no. Drug-induced, very unlikely, okay? I mean, potentially if she's been on it like suddenly in the short term, but she hasn't. Immune thrombocytopenia, yes, okay. Not a leukemia because, again, no splenomegaly, which is something commonly you get in leukemia, and it's only been 1 week. So leukemia, unless it's something like an acute blast crisis, is not going to happen that quickly. A viral illness, yes, but it wouldn't explain why she's getting the bleeding and the bruising. So ITP. So let's talk about ITP quickly. So we're talking about it with a PEDS mindset because that's usually where you're going to see it. So it's the most common bleeding disorder in children. The reason we get it is after a viral illness, we develop these antibodies, so IgG antibodies against platelets. So that causes platelet destruction. So that's why it's called immune thrombocytopenia. Okay, because it's an autoimmune process that causes our spleen to eat up all of our platelets. Okay, so how would it present? So there's 2 ways, acute and chronic, and they're very different in how they present. So acute is going to be most babies with these petechiae and the purpura. So usually secondary to a virus, and it usually resolves by itself. Okay, a chronic is somebody who has these ITP symptoms for more than 6 months. Okay, so that's important, more than 6 months. And sometimes they can have the bleeding symptoms. All right. And the main thing that we're worried about with somebody with ITP, why it's important, is because they can have an intracranial hemorrhage. So that's the most important part, because we have a clotting disorder, they can have an intracranial hemorrhage. All right. Now down here is the most important part. Okay. This is really, really, really important. The reason it's important is because ITP is a diagnosis of exclusion. Okay. So you only diagnose someone with ITP when nothing else better explains their symptoms. And there's a reason for that. Because we need to do this, right? Thrombocytopenia has many different causes, and you need to rule out every single one of those causes before you can call it ITP. So for example, thrombocytopenic causes, so things that affect the platelets. All these conditions are based on the fact that this patient is presenting with petechiae. So keep that in mind. So the history of presenting complaint is petechiae. So how do we approach a patient with petechiae? We look for one, either a thrombocytopenic cause, so a platelet cause, or a non-platelet cause. Okay. So platelet causes, we talked about ITP, we talked about leukemia, and we talked about DIC. If somebody had DIC, they'd be much more unwell. If somebody had leukemia, they'd have other suggestive features, but children can always present differently. Okay, non-thrombocytopenic cause. So you need to rule this out for sure. You need to rule out HSP. You need to rule out that they haven't had a diarrheal illness, so they haven't had hemolytic uremic syndrome. You need to rule out trauma. Okay, so trauma is a underappreciated cause of petechiae. So trauma causes capillary damage, and that capillary damage causes blood to leak out, and that is what causes your petechiae. So petechiae is not always thrombocytopenic in nature. So the point I'm trying to get across to you, imagine you're in an OSCE station. I always come back to this example. Imagine you're in an OSCE station. What your examiner is looking for, are you able to think about and rule out red flag conditions? Because again, reiterating the point, ITP is a diagnosis of exclusion. Any patient who has lymphadenopathy, any patient who has hepatosplenomegaly, instantly rules out ITP. Okay? So this is just a good table that you can look at, and I'll leave that there. You can have a look at it later. So how are we going to manage it? So usually spontaneous. In some situations, we can give IV, IG, and prednisolone. So that we don't always use that because it hasn't been shown to improve it that much, but it can decrease the time to resolution of symptoms. Okay? Okay, that's all. I'll leave it there. Why have I got that picture there? Oops. That's the spleen. Okay, so we've talked about ITP. I also wanted to talk about leukemias quickly. Now, when I was saying at the start that I apologize for having a lot of breadth but not a lot of depth, this is going to be particularly apparent when I talk about leukemias. This is a very hard topic. It's a huge topic. I can't believe how much there actually is to know about leukemia. So the best that I can do is trying to help you with some questions and try and give you the best differentiating features that I was able to find. Okay. So again, I apologize in advance. I don't know that much about leukemias. It was really hard when I was actually researching this. Okay. So this is well, I made this picture, but I actually don't think it's that good now looking back at it. So we'll just start with this. Okay. So differentiating between ALL and CLL. So acute lymphocytic leukemia. So the first thing to understand is that this affects your lymphocytic lineage, not your myeloid lineage. Okay, so these are your myeloid cells, which make these cells, and lymphocytes make these cells. Okay, that's very important when we look at some exam questions and when we look at the results on an FBE. So we'll talk about it soon. Okay, so ALL, first of all. So this is when your lymphoid progenitor, so the one that can make all of your cells, like your daddy cell, that one becomes altered. So it's through some kind of mutation. It's usually some kind of spontaneous somatic mutation. So somatic means that it can't be inherited. So it's not affecting your sex cells. So you can't give it to your children. So it's a somatic mutation that results in uncontrolled proliferation. So proliferation is important because that's the underlying feature of all leukemias and all lymphomas. You have this single type of cell that is being produced, so nothing else can be produced. So imagine that we're working in a factory. So we're working in a biscuit factory where, you can go to Coles, you can buy family assorted biscuits, right? So imagine one factory makes all of those biscuits, but the factory now starts to make Scotch fingers and nothing else. So everything else starts to become less, and only Scotch fingers are produced in large amounts. But because they're doing it so quickly, they have no quality control. So the Scotch fingers turn out to have, they don't taste very good. It's a very similar thing for leukemia. Because one cell is starting to proliferate so much, it pushes everything else out, which is why every single leukemia has 3 or 4 common symptoms. One is anemia, one is infections, and one is bleeding, okay? So anemia because all of your red blood cells are produced less. Infections because you have no mature neutrophils or white cells to be able to combat infection. And bleeding because you have decreased amount of platelets. So the key differentiating feature between chronic and acute leukemias is time frame. So acute leukemias happen in a much quicker time period, whereas a chronic leukemia progresses throughout your life period, so of many years. And also the main differentiating feature is age of onset. So there are some conditions that affect children. So for example, ALL is the most common pediatric cancer. All right, so that's important. Leukemias are the most common pediatric cancer, and ALL specifically, 60% of patients are diagnosed by the time they're 14. So ALL is going to present in the pediatric population, whereas CLL is going to present in the adult population, and it's the most common overall leukemia in Australia. So ALL, CLL, very common. One is pediatric, one is adult. The symptoms are going to be the same. The difference is how quickly and over what kind of time period you're going to get those symptoms. So that's really the best explanation that I can give you. Okay. Now, this is important. So if you do a bone marrow aspirate and more than 20% of the cells are blasts, that indicates that this is an acute leukemia. So something like CML, if you guys remember CML, you remember how CML has 3 stages? So the last stage of CML is a blast crisis. And blast crisis is defined by having more than, I think it's 30% blasts on a blood film. So that is why blasts are important, because blasts are essentially non-functioning cells. So 1/5 of your production doesn't work, so that's why you get very sick. Okay, so smear cells. So smear cells are something that you see in CLL, and that is due to damage of the cell wall because these are very immature cells. When they spread out all of that blood on the film, those cells become they burst and they smear on the film. Okay. Okay, so that's really the best I can do for explaining these conditions. So CLL, ALL, lymphoid cells. Okay, difference between all leukemias is the age of onset and how quickly the symptoms develop. Okay, so then we'll talk about AML and CML. So AML is your myeloid cell, so myeloid, right here. And again, the symptoms are the same: anemia, infection, and bleeding. But AML is a very rare condition. However, it's associated with a few particular things. One of them that you need to know in particular is Down syndrome. So people with Down syndrome have a much higher risk ratio of developing AML. So that's an important thing that you need to do. Fanconi's anemia, again, is something that's come up on past exams. And somebody who's had chemotherapy or radiation in the past have an increased risk of developing AML. Okay, now CML. So CML is again, so ignore this. This isn't exactly correct. So don't look at that. All you need to know is affecting your myeloid cells. So this is a chronic progression of symptoms, and it has 3 phases. So 90% of people are diagnosed just incidentally with chronic symptoms. So 90% of people are diagnosed in the chronic stage. An accelerated stage is despite the management of the leukemia, so potentially with chemotherapy, they start to progress. And then blast crisis, that resembles acute leukemia. So acute leukemia is all of the same symptoms, but in a much quicker setting. So they get frequent infections. They're always anemic, they're always pale, lethargic, and tired. They get B symptoms. So more than 30% of blast is diagnostic for a blast crisis. Okay, so again,
In chronic, does that mean not all of the lineages are affected yet? Like the chronic stage.
well, the thing is that it's affecting your myeloid cells. So all of these cells, your basophils, your neutrophils, your eosinophils, and monocytes. So what you would see is you still see an increase in white cell count, but they wouldn't have the same symptoms. Or at the very least, you'd have a slow progression of increase. We'll see it in the question soon. So just hold on.
What do you mean increase in white cell count?
I'll show you. Okay? Because remember, all of these conditions are a proliferation of cells that are non-functioning. Okay? Now, one thing, a buzzword that you need to know is the Philadelphia chromosome. The Philadelphia chromosome is important because that identification of that chromosome has allowed us to develop a treatment for CML, which is imatinib. Do you guys remember learning about imatinib in second year? So imatinib is a tyrosine kinase inhibitor. So the reason we were able to develop something so specific is because we were able to identify the chromosome that is causing CML. So it's a tyrosine kinase abnormality. Okay. All right, so let's go through some questions to try and understand the difference between these common leukemias. Okay, so we have an old man. So what can we instantly rule out? ALL. So we can rule out ALL and most acute stuff, so not AML. So here's fatigue, night sweats, and early satiety. Why is he getting early satiety? Satiety? by this. So this is the spleen. So normally the spleen should not be that large. So exactly as he said, compressing the stomach causes them to get fuller quicker. All right, so he has a white blood cell count done and is 34. So is that, so I mean, I know it says 1,000, but it correlates to our lab values anyway. So normally white blood cells should be less than 10. So this guy is 34. So it's 3 times the upper limit. Okay, less than 3% blast. So less than 3% blast rules out, again, any acute leukemias. Okay. And what are they? They're promyelocytes, myelocytes, basophils, eosinophils. So notably, he doesn't have any increase in lymphocytes. So he doesn't have B cells or T cells. So the diagnosis, therefore, must be a myeloid pathology. We know it's chronic, so the diagnosis is CML.
Oh, right.
Yeah. So so he doesn't have any increase in lymphocytes. So it's not going to be ALL and it's not going to be CLL, even though CLL will fit well because of the age. Because myeloid cells are increased, and we know that it's not acute because he doesn't have blast, it's going to be CML. Okay. And again, like I told you, all of the symptoms are going to be very similar for every single leukemia. So the answer here is CML.
3% blast isn't that high.
Well, when it becomes 10%, then you could call it acute. Okay. So again, an old man, he has fatigue, so no specific symptoms. So easy bruisability. That's why you always need to check for thrombocytic and non-thrombocytic causes of thrombocytopenia or petechiae. He looks ill. He has some cervical lymph nodes, which are palpable spleen, and a few petechiae. So what would you do? Right, so you do the white blood cells because you think he has leukemia. Hepatosplenomegaly, B symptoms, so having night sweats, having these long-term, it makes you think malignancy. Okay, so when you do the smear, what you see is this. So that really does look like a smudge. So because of the damage to the cell wall in something like leukemia, when they spread out the blood cells, you get these smudge cells, which are indicative of CLL. Okay, so maybe it tells you here. So he has lymphocytes. Okay, he has many lymphocytes. So CLL. Okay, so same patient. 4 weeks later, he has a rash. Okay, so platelet counts is 10 and 30% of neoplastic lymphocytes. So he has some hematopoiesis and megakaryocytes. I mean, this is a bit of a hard question, but you'd give him prednisolone. Okay, so what's happening here is a rare complication of CLL, something called autoimmune thrombocytopenia. And the way that you manage that is with prednisolone. So that's a bit of a difficult question. Okay. So I think we'll skip this, okay? So what this question was going to be is indications for when you start chemotherapy. But what I'm trying to say, chemotherapy is a good good thing that you can do. So we'll skip that one. All right. I'll skip that one too. All right. Now, this is just a good picture. So this was going to be this patient. But what you see is these little nucleophilic projections. So that's called hairy cell leukemia. So just something that you can see on blood smear. Okay. All right. So we've done that. Was there anything else I want to talk about? No, we'll leave it at that. All right. So that was just a very quick way to try and approach leukemia. Again, I'm sorry, there's very little depth, but what can I do? All right. So 30 years old. He's had a car accident. He's come to the ED. Severe back pain. He's tender over the mid-thoracic spine. Right lower limb. So if we drew a man, okay, it could be a woman. I'm not trying to be sexist.
It does say man.
Okay, good. Okay, so what does he have? He's a right. So we'll say this is a right. Say this is left. So right lower limb is weak. So something there. He's areflexic with loss of sensation. And the left lower limb has normal power, but he has loss of pain and temperature. So there's no pain. And there's no temperature here. And here he has no motor. And he has no vibration plus proprioception. Okay. All right. So what spinal tracts are affected? So pain and temperature is spinothalamic. And here, DCML, as well as, which is corticospinal tract. So see, I use CCS a lot. So which side do you think the lesion is on? right side. Why do you think that?
DCML only decayes further up, so at this point you're cutting it on the same side.
Yeah. So what happens? So if you remember back to your second year anatomy, so the spinal tracts decussate. So decussate means change to the other side at different points. So the so the motor tracts and the vibration proprioception tracts, these decide to decussate all the way up in the brain. So when they're all the way up here in your brain at the top of your body, they already decide which side they want to innervate. So it's coming from the left side of your head, and before it leaves your brain, it decides that it's going to innervate the right side of your body. Whereas the spinothalamic tract decides that it's going to innervate the right side of your body when it's already there. Okay, so it's traveling on the left side of your spine before it actually gets to that innervation location. So it hasn't made its mind up. So that means that when we cut so if we have a spinal cord and we're cutting it at that section, our spinothalamic tract still hasn't made up its mind. So that's why we lose it on the left side. Whereas when we cut it here, DCML and the corticospinal tract have already made up their mind, which is why we lose it on the right side. So what's the answer?
Right.
Okay. So what's the condition? Brown-Séquard syndrome. So this is Brown-Séquard syndrome. So half of our spine is affected. So we have DCML, which is up here. Again, it's already decided up in the brain that it's going to innervate the right side. Okay. We have our corticospinal tract that's affected here. So that, again, already up in the brain is decided. But here, the spinothalamic tract still hasn't made up its mind. So even though it's traveling on this side, it's going to affect, so it's traveling in the opposite side, right? So it hasn't made up its mind which side it's going to innervate. Yeah, so that's Brown-Séquard syndrome. All right. Now, how about if, actually, we do have this. Okay. So this is an older lady. So she's also had a motor vehicle accident. She has trouble raising her arms. She is able to weakly resist pressure. She has a sensory deficit from the mid-torso down, some neck pain, and she's incontinent. Does anybody know what this is? So this is central cord syndrome. So central cord syndrome is the most common form of an incomplete spinal cord injury. So if we look here, so this is so it's affecting kind of everything, but it's not affecting everything really well, which is why she has kind of uncertain features that wouldn't allow you to locate the symptoms exactly.
There's the cervical nerves and the motors closest to the center.
Maybe.
Yeah, but I don't know why she gets the urinary retention.
Well, the urinary retention is very common with people who have an upper motor neuron lesion. So urinary retention is something that's very common, and yeah, we'll leave it at that. Okay, so coming back to leukemia, so we have an old man. So he has had a painless lump in his neck, so he has lymphadenopathy. So we can instantly rule out ITP. So lymphadenopathy, he's lost weight and less interested in food, so he probably has hepatosplenomegaly. Easily tired, so he has anemia. Okay, and so we've done that. All right. So currently 103. So it's been steadily decreasing, right? So 128 to 111 to 103. White cell count has been steadily increasing. So he's had a clonal proliferation. So we know his white cell counts are high, but we don't know what white cell counts are. Why is that important? Because we need to know whether it's lymphocytes or whether it's neutrophils. Okay, so let's see if, look what it tells us there. His lymphocytes are high. So therefore, the diagnosis is CLL. That one. Okay, what is this? Was it diffuse B-cell large non-Hodgkin's lymphoma? DLBCL. So DLBCL is something that can happen after you get CLL. So a rare complication of CLL is something called a Richter's transformation. Have you guys heard of that? I think a lot of you would have heard of that, Richter's transformation. So that's a rare complication, around 5 to 10% of people, where the CLL, which is a small lymphocytic lymphoma, transforms into this very rapidly growing lymphoma. So that becomes a DLBCL. And DLBCL is a type of non-Hodgkin's. So oncology gets really complicated, but non-Hodgkin's lymphoma is just an umbrella term for many different conditions. And the most common condition is diffuse large B-cell lymphoma. CLL is also a type of lymphoma because it's a proliferation of lymphocytes. So there's just a lot of terminology that's hard to understand, but DLBCL is just something that can happen after you get CLL.
Why couldn't it just be DLBCL?
because it's not rapidly progressing. So DLBCL is a rapidly progressive. 3 months. 3 months isn't that quick, and he's had these so he's had these symptoms since 2 years ago, right? It's rapidly increasing. Okay, and the thing with CLL, like I told you, is insidious in onset. So that's why it's been happening for 2 years, but he's only now presenting because now his symptoms are getting bad enough. Okay. All right. So we have an 85-year-old female. She had colon cancer 7 years ago that was resected, and she's coming to the ED with abdominal pain. So she looks pale. Her BP is a little bit high. Heart rate is relatively normal, and her oxygen stats are good. You notice this hard mass in her tummy, and she has some tenderness. The urinary catheter drains 200 mils. Is that normal? No. 200 mils is less. That was probably indicative of some kind of retention. All right. So you do this CT. How could her renal function be improved? Now, I actually went all the way down to radiology to make sure that I could explain the CT to you guys properly. So let's go through the CT. What is this? No, what organ is this?
What?
This one.
Oh,
Liver. What's this? Spleen. Okay. What's this? So in a female, what is above the bladder? The uterus. So this is the uterus. And is that a normal size? So normally the uterus should be as large or smaller than the femoral heads. So this is the head of the femur. So this one is significantly larger than that. Okay. So potentially she has. What's the first thing that comes to mind when you have an elderly female who has a large uterus? What's the most common thing? Fibroid. So she potentially has fibroid. Maybe she has cancer, but that's very unlikely. Colon cancer usually metastasizes to something like the liver. So very rare for her to go to the uterus. So it's uncertain why she has this large uterus. Most likely is fibroids, but you don't know that for sure. Okay, so fibroids, maybe malignancy, maybe cancer. But cancer, again, is unlikely to cause a massively, well, it wouldn't cause a uterus to be this large. So this here is the bladder. So what you notice is on a CT, on this CT at least, fluid is dark. So you notice this little bit of fluid. So that's the bladder. And here, so this is just part of the colon. This is the vertebra. So you notice that she probably also has a scoliosis. And this here, so it's very hard to tell what that is unless you can actually scroll through. But this is probably the femoral vein. And then these are the psoas muscles. Okay. Which leaves these structures. So what is this structure? So this is the kidney. Is that a normal kidney? No. So what do you notice here? So I told you that something that is dark is fluid. So what do you notice here? Yeah, so she has this dilatation. So she has hydronephrosis. So I've put this little picture up here to show you what a normal kidney looks like. So in the normal CT, you can see the structure of the renal pelvis really well, and it doesn't look dilated like that. Whereas here, you can see a massive dilation on both sides. So because it's on both sides, it's unlikely that it's going to be like a unilateral hydroureter, where she has an acute blockage of a ureter. What's happening is that she's blocking down here, and she's blocking the insertion of the ureters on both sides that causes the nephrosis on both sides. So how are we going to improve her renal function, understanding what her problem is now? Insert some stents. Okay, so what is the difference between the ureteric stent and a nephrostomy tube? Okay, so a nephrostomy tube is something that is that you insert percutaneously, and you insert a large needle right into the renal pelvis to try and drain it. Okay, whereas a ureteric stent is something that you usually use for more chronic cases. So let's say if you have somebody who has a tumor, they're not able to operate on immediately, then the ureteric stent is something that can allow the drainage and improvement of that flow whilst you wait for management. So usually a nephrostomy tube would be used for an acute setting, whereas a ureteric stent, so we'll put a stent there, is going to be used for the more chronic setting. So that's why ureteric stent is the correct answer.
You do it bilaterally?
Yes. So suprapubic catheter, when would we use that? So potentially retention. So yeah, so bladder. So if we insert a normal indwelling catheter and that doesn't work, then we might try suprapubic catheter. But in that case, that is not going to be the definitive management for her condition. Furosemide, that is definitely not appropriate in this case. Packed blood cells. I mean, that is not. I mean, the question that is reasonable. It is a consideration, but the question is asking us specifically, how are we going to improve her renal function? and packed red blood cells are not going to improve her renal function. But you definitely would consider it given that her HB is that low. But you also need to look at her baseline. And then IV saline is not going to help her either. All right. Does that make sense? I was very happy when I went into radiology and actually able to explain and go through that image. I thought it helped a lot. So I was going to have a nephrostomy video there, but we'll skip that for today.
So the stents go through the...
Yeah, so I wish I could. So usually, so the insertion of a stent, they insert a cystoscope first, and then you have your guide wire and your tube. So it's like a rubber tube. So remember, so if we have our bladder, so we have our bladder here, right? And remember, it's shaped like a triangle. That's why we call it the trigone. And up here, we have one ureter and two ureters that are inserting. So insert a camera into here to have a look. Then we insert our guide tube and we go through there. And then we push the stent through that tube all the way to the kidneys. Make sense? So that's how you insert a stent. All right.
Would a catheter, would that be similar? Would that be have a similar efficacy to stents?
Well, not in this case, because the pathology here was, well, the pathology isn't down here. The pathology is up here. So inserting the stent will only allow us to drain whatever urine is in there. And we've already tried it, only drained 200 mils, okay? The problem is the fact here. So another important thing that I didn't mention is that her creatinine is 400. Now, creatinine is a good estimation of your renal function. That's how we estimate GFR, right? Estimated GFR is based on your creatinine clearance. Why is creatinine used? This is going back to first or second year, good via photo, I guess, is creatinine isn't absorbed by any of the renal tubules, which is why it gives us a good estimation of the renal function. So creatinine is very high, indicates that she has some renal dysfunction. And the only way we're going to manage that is by removing all of that fluid. And we can only do that is if we expand or dilate those tubes.
So the fibers are compressing the ureter.
Well, yes. Well, they're compressing the bladder, at the very least, that what I can see, and it's probably compressing the ureters, which is evident because she has hydronephrosis on both sides.
But if the stents go up, it's like the instruction like that, the bladder.
Well, the thing is, well, you're inserting a hard tube, which is not going to be, well, for example, like if I had a metal tube, right, and I try to squeeze it, what's going to happen to the metal tube? Nothing, because it's harder than the soft mass that's pressing on it. So we insert something hard that is going to give us a patent passage for that urine to drain. That's why we insert the stents. Yes.
Oh, okay.
Right. Well, I guess I didn't explain that. So I'll draw it so you guys can see clearly. So this would be our stent, okay? That's how it would look like. And that's going to allow the drainage and improve the hydronephrosis, okay? It's easier than you think. So you just insert it through that hole and then it just naturally follows through, okay? Very good. All right, so we have an elderly woman. She has epigastric pain, nausea, shortness of breath. All right, what I'm going to do is, which artery is going to give you an arrhythmia? Yes, so right. So that's what she has. She has an arrhythmia. She has, look at it, we have increasing PI intervals. She has first degree heart block. Okay, likely due to the right coronary artery. Yep. Yes. Okay. What's this? All right. So this lady, I'm just gonna try to go through this quickly just for the sake of time. So this lady has rheumatoid arthritis. Rheumatoid arthritis can affect which of these cervical joints? So rheumatoid arthritis is an inflammatory arthritis that affects your synovial joints. Which part of your cervical spine has a synovium? C1 and C2, which is called the atlantoaxial joint. That's why rheumatoid arthritis is a cause of atlantoaxial instability. So the answer in this case would be C1, C2. Okay, so this patient, so she's breathless. So she has a pleural effusion, and we're trying to find out why she's having a pleural effusion. So we do a pleurocentesis, and we find that the 16, so 16 versus 36 is 8, oh, I don't know. Pretend that was 38. What's 16 times 2? 30, whoops, 36.
4.9.
4, is it 4.9? Which is less than 0.5. Anyway, okay, so she doesn't, so this is Leitch criteria. Have you guys heard of Leitch criteria? So the only thing you need to know about Leitch criteria is exudative versus transudative. That's the reason we use it. We're trying to find out whether this pleural effusion is caused by an exudative process. What are exudative processes? Yeah, so anything that is pathological, infarction, malignancy, infections, these things are pathological. They're not, well, nothing is normal, but they're more abnormal than other things. whereas transidative is a natural body process. So any kind of failure in the body, heart failure, kidney failure, liver failure, any of these things can cause you a transidative. And the way that we differentiate is that if there's a high amount of albumin inside of that pleural fluid versus what is in our serum, that's exudative. So in this case, it's less than 0.5. So she has a transudative pleural effusion. And what's the only one in this list that is transudative? Cardiac failure. Even if you didn't know last criteria, this is pick out the odd one out, okay? So that one is exudative, right? So that's infectious. That one is infectious. That's infectious. That one is infarction. So the only odd one out is the fact that we have cardiac failure, right? Okay. So young man, he has diabetes, comes to the ED because he's being confused, so he has some altered conscious state. He's been unwell for several days with a viral infection. That is so important. I want to reiterate this point again. Chronic conditions do not present to hospital unless there is a precipitant, right? So chronic conditions are managed in the community. Someone with heart failure doesn't need to come to hospital. They're managed by their GP on medications. The only reason they come to hospital is because they've had a decompensation. What causes a decompensation? Infection, infarction, anemia. All of these different things causes you to decompensate. The fact that he's been ill is the precipitating factor. So drowsy, withdrawals to pain. So he has very low GCS, right? His temperature is 35.2. Is that hypothermia or not?
Borderline.
It's borderline. So you need to be less than 35 to be called hypothermia. Rest rate is relatively normal. He's sitting well, and he's got a very low glucose. What is the diagnosis? What is he presenting with? Okay. Is he presenting with DKA?
No.
Why?
DK would have a high glucose.
Exactly. So this is a hypoglycemia. So he's not presenting in DK. That's important to know. He's presenting with hyperglycemia. That is his presenting condition. Hyperglycemia can have many causes. Most common cause, especially in the diabetic population, is too much insulin, okay? Or the fact that he's been ill, so that he probably hasn't been able to titrate his insulin properly. So when you're ill, your insulin requirements differ, right? So maybe when he's used his normal dose of insulin, it's been a bit too much for what he needs at the moment. So he's injected insulin, and that's causing him to have hyperglycemia. Now, what single investigation do we need to do for somebody who's presenting with new onset or first-time hyperglycemia without diagnosed diabetes? C-peptide. Why do we need to do C-peptide?
To see whether they're producing too much insulin or if it's like exogenous.
Exactly. So we do C-peptide to then help us to go down the pathway of whether we need to investigate for an insulinoma or not. So it's something in the body that endogenously releases insulin. Because for a normal person, there shouldn't be any situation where you have hyperglycemia. Your body has adequate glycogen stores. You can have glycogenolysis and glyconeogenesis that should allow you to keep your glucose within normal levels for a normal person. So it's abnormal to have hyperglycemia, so to have a glucose less than 3.9. So in this situation, what do we need to give him immediately? Why? IM glucagon or IV glucose?
I think maybe in community I am glucagon, in hospital.
So he's in hospital. Okay, so we need to give him IV glucose. Okay, so if we have a look at this chart, this is from prompt. So again, reiterating the point for the millionth time, look up guidelines, prompt, IRC, GP, whatever it is. So we can go through this. So it says conscious state. He's definitely, well, he may as well be unconscious, so he can't take food. If he could take food, then you just give him a banana, right? You give him a banana or you give him some glucagon syrup. That's what glucose scan. You give him some glucose scan syrup, but really banana is really the best thing. So unconscious, so we need to call a MEC call. Can we get IV access? Answer is yes. Everyone in ED gets a cannula. So unless there's some kind of contraindication, which you couldn't identify in the question, he's going to get IV access. So we give him IV glucose. If he couldn't get IV access, then yes, you would be correct. We'd give him glucagon. However, the evidence does show that IV glucose has quicker onset of action and decreases the length of hypoglycemia and how long they're in an unconscious state for. It's not by much, but it does have a difference in effect. All right, and then another important thing, I've told you this before, but it's important for me to go on again. There doesn't exist a situation, to my knowledge, where you would ever withhold a type 1 diabetic's insulin, long-acting insulin, never. There's no situation where you would do that. So just remember that point. I'm going to skip this question because I don't know how to explain it. The answer here is multinodular goiter. So this patient is presenting with a single mobile lump. So the only evidence or the only explanation I can give you for why the answer is multinodular goiter is one, because multinodular goiter is epidemiologically the most common, and second, multinodular goiter can present with a single node that is most prominent. Other than that, I'm not sure how the other features in this question are ruled out. The only things that I could rule out is something like thyroid cancer because they don't have lymphadenopathy, Hashimoto's because they're euthyroid, but the other three, I'm not able to explain why you can differentiate between them, okay? I spent a long time, but I can't give you a definitive answer.
Would a cyst be growing as opposed to?
Well, the faculty answer is multinodular goiter. And like I said, I can't explain why that's the best answer other than those 2 points that I gave you. Okay, so I was going to talk about hot and cold nodules, but we might not have time. Okay. All right. So 65, he has weight loss and malaise, cachectic. So he has some kind of cancer. Left supraclavicular fossa. So, okay, so that's a bit low. That's normal. So he doesn't have leukemia. His platelets, that's normal enough. Okay. Mean cell volume. He has a bit of anemia. Okay. What do you think he has? Why does he have gastric cancer? Yes, because he's had malignancy to Virchow's node. So 90% of left supraclavicular lymphadenopathy is from a GIT malignancy or something like that. It's very common. All right. So, I mean, there's a lot to talk about for lung cancer, but there's just a few points that I'm going to explain. So, older woman, she's a long-term smoker. That's really important because if we do a table, adenocarcinoma is the most common cancer. Small cell lung cancer only makes up a small proportion. However, that much of it is due to people who are smokers. So like 99%. Whereas for adenocarcinoma, it's more like that. Make sense? All right. So smoking is important. She has a cough. She has right shoulder pain, tenderness of the right upper arm. Why does she have that? Because she probably has metastases to her shoulder. Independent for all tasks of daily living is a very important point that they put in the question. So it's independent with ADLs. 4 centimeter right hilar mass. So she has hilar lymphadenopathy, multiple liver lesions. She has small cell lung cancer. So why have they put all of these in?
LU surgery is not appropriate.
Yes, that's very good point. And another point is the natural history for small cell lung cancer is that it's only in like 90% of cases is only identified once it's already metastasized. That's how it's usually found. And that is why it has such an abysmal 5-year mortality rate of only like 1%. Okay. So she has skeletal metastases, so all of that. So again, another important point, she would like to have treatment if possible. So there's 2 key factors in this question that help you to differentiate between 2 very reasonable answers. One is the fact that she's independent with all of her activities of daily living. And the other one is that she would like to have treatment if possible. So I'm just going to go ahead and exactly as Kieran said, if you have metastases, you're not allowed to have surgery. Okay. Radiotherapy is not going to manage her symptoms. That is not something that you do. So there's 2 things. Do we give her chemotherapy or do we palliate her? What's the answer?
In this case, probably chemotherapy and consider palliation later down the line. She's independent with chemotherapy and probably give her up to 2 years.
Yes. Okay. Very good. Perfect. That's a good answer. So like I was saying, both answers are reasonable because in the real life setting, you probably would palliate her at the same time that you're giving her, or the palliative team would probably organize the chemotherapy. But this question is asking us specifically what is the best treatment right now. The answer is chemoradiotherapy. The reason for that is unlike other lung cancers, small cell lung cancer is exquisitely responsive to chemoradiotherapy. So another thing is, small cell lung cancer is broken down into 2 categories. Okay, one category is non-metastasized version. The other one is metastasized version. So people who have the non-metastasized version, nearly 75, well, up to, so it's a very wide range, but up to 75% of those patients have a complete response to chemotherapy. Even people who have metastases, up to 30% have a complete response to chemotherapy. So I'm not sure if complete response actually means curative. I'm not sure if that's what it means, but complete response sounds pretty good to me, which is why chemoradiotherapy is something that you always do for people who have small cell lung cancer, unless they're explicitly refusing it. And as Kieran said, those other features help us to rule out palliation. Does that make sense? Okay. All right. So we have a young man. He has worsening pain in his left wrist and both knee and ankle joints. What is that called? Polyarthritis, exactly. So he has polyarthritis. Okay. The onset was a week ago, no recent trauma. So because it's a week ago, it's unlikely to be something like OA or RA, right? He's been feeling feverish at various times and has had some dysuria, and he has no significant past medical history. I've crossed this out for a particular reason. Smokes marijuana occasionally, denies any other illicit drug use. Does he have septic arthritis? No, he has no fever, and he has no acutely swollen joint. Usually, a unilateral joint would be indicative of septic arthritis. Does he have psoriatic? It's acute in onset. He doesn't have any hand involvement. He has no plaques, so unlikely to be that. Is it gout? Is polyarthritis? Is it reactive arthritis? Yes. Is it JIA? Unlikely. So JIA could present. JIA has a lot of extra-articular manifestations. You'll understand why D is the answer if I reveal what that says. So that says that he was sexually active, but the reason that with multiple sexual partners, but the reason I've crossed that out is because reactive arthritis is more likely to be usually a GIT illness. Okay. Now the fact that he's had dysuria indicates that he might be having what? Reiter syndrome. So what's Reiter syndrome? So can't see, can't be conclamatry. So urethritis, uveitis, and arthritis. So that's what those three are. So it's not normal. So if you got a GIT illness, would you get reactive arthritis?
Probably not.
Probably not. So reactive arthritis comes under the umbrella term spondyloarthropathy, so seronegative. So these are people who are HLA-B27 positive. So I remember last time I was telling you about how angstbond is 90% HLA-B27 positive. So same with reactive arthritis. Usually these patients are something like 80% positive. So HLA-B27 is a risk factor for getting reactive arthritis because it's not normal to have a viral illness and then get arthritis. So Reiter syndrome was actually found in World War II when people who were fighting in the trenches were getting dysenteric illnesses. Then after getting this dysentery, they were getting this can't see, can't pee, can't climb a tree. So that's when we found out about it. So STIs are still really common, so chlamydia, gonorrhea, but things like Campylobacter, Yersinia, E. coli, these also cause reactive arthritis. So usually develops within 4 weeks of illness and lasts for up to 4 to 6 months. So it's a very long-term condition. I'm not sure. What is the management, I think? I'm not sure what the management is. But anyway, what's this picture? So this is keratoderma, I don't know how to spell it, Blenner or Hagika. Yeah, Blennerhagia. Okay, so these are these waxy brown plaques on the palms and the soles that usually occurs within the first 1 to 2 months of getting reactive arthritis, and usually it's due to the STI-related ones because chlamydia can often be isolated from these little lesions, and it's very common actually. It's more common than you think. I think something like 15% of people get it, or it might be higher. It's very common. Is what I'm trying to get at. I'm going to leave that for you to memorize. So room antibodies. I'll just quickly HLA-B27. Seronegative. D, this one. Celiac. DR2. Yeah, me neither. I can't remember the others. Okay, so celiac, that's important. Seronegative, we got those two. Oh, I would never have been able to remember that one. Autoimmune diabetes, oh, that's really, really important. So type 1 diabetes, you usually do a HLA screen as well as what? What other antibodies do you do? Anti-GAD and IL-2. And then DR5, I didn't know that one either. Okay. Oh, God.
How many more?
We'll finish soon. When we hit the women's questions, we'll just finish that. Okay. So 45-year-old, weight loss, broken sleep, and thirst. His sleep is broken because he's been getting up multiple nights to pass urine. What's that called? Nocturia. Okay. Is nocturia normal?
Once.
Yes, it can. Well, yes, once, but then that's not really nocturia. So nocturia is something that is very age dependent. So 70% of people by the time they're 70 years old do get nocturia. The reason for that is because you have some changes to your ADH. So by the time you're old, you have what happens? So by the time you're old, the amount of ADH that is released normally should increase when you're sleeping, but when you're old, that doesn't happen anymore. So you're not saving all that water and you're peeing it out. So in this case, what's happened? So his NA, so he has hyponatremia, hyperkalemia. His urine, or his urea is a little bit high. Creatinine is normal, so he has normal renal function. we'll talk about it. His serum osmolality is that, what is that? That's high. And his urine is not necessarily low, but it's on the low range. So he has low urine osmolality, so urine osmoles, and he has high serum osmoles. So what does he have? So he's making large amounts of dilute urine. So he has diabetes insipidus, okay? So diabetes insipidus is of two types, right? You have nephrogenic or you have neurogenic. So normally in the hypothalamus, our hypothalamus regulates two things, right? It regulates one, urine production through the function of ADH, and it also regulates thirst through our ventromedial nucleus. So how does it regulate thirst? It has osmoreceptors. So it detects what our serum osmolality is. That's important because in diabetes insipidus, what happens to our serum osmolality? It goes up, right? Because we're losing so much water, all our electrolytes go up. So our sodium is high. That stimulates the hypothalamus, which stimulates our thirst, and it causes us to drink more. So now we have a polydipsia, polyuria cycle. So we drink more and we pee more. So the only way to break that cycle is by preventing the hypothalamus or by normalizing those osmoreceptors in the hypothalamus. How do we fix that? By fixing sodium. How do we fix sodium? Not diet. Well, yes. But what medication do we give? Not a loop or a thiazide diuretic, because thiazide works directly on the NaCl channel. Okay. So that's why the answer to this question is amiloride. So amiloride is not a thiazide diuretic. It's an ENaC inhibitor. So it inhibits the reabsorption of sodium from your collecting tubules or something like that, ENaC. So that's your free sodium channel. So normally the first line therapy for somebody who has diabetes insipidus to break that polydipsia polyuria cycle is by giving them hydrochlorothiazide / amiloride. So a lot of people, so if it was neurogenic, then we'd give this one, right? Vasopressin. Because neurogenic is usually from some kind of pituitary surgery, a pituitary infarction. Lithium toxicity is for nephrogenic. So having ADH being secreted less. But this is nephrogenic. So nephrogenic is more common in lithium toxicity, in having polycystic kidney disease. So we need to break that cycle, and we break that cycle by normalizing sodium. Make sense? Okay, so young woman, she's hirsute, puffy cheeks, truncal obesity. What does she have? Cushing's. Cushing's is usually due to, in most cases, from. So what's the cause of the Cushing's? The primary cause. Why do we get excess cortisol secretion? Okay, first of all, where's the cortisol being secreted from? Adrenals. So what's likely going to be with the adrenals? They're going to be large. Okay, but what is stimulating the adrenals to release all of that cortisol? So pituitary tumor. So pituitary adenoma is the most common cause of Cushing's disease. However, this is asking us most likely done in ultrasonography. You can't ultrasound the head. So what you're going to see is these bilateral adrenal masses because they're going to be very large. Make sense? There's a lot of different causes of Cushing's, but because this question doesn't give us any more information, we have to go on the epidemiological knowledge. Epidemiologically, most common cause is pituitary adenoma. Adenoma causes hypertrophy of the adrenals. Yes? Okay. Well, wasn't that a nice transition? That's just a picture. And in this question, she had osteoporosis, she had diabetes, she had skin changes. She might have ulcers, I can't remember, but she's had a lot of features of Cushing's disease. So the way you remember the features of steroid or steroid side effects is Cushingoid. So that's just a good table to have. All right, so we're now done. So these are the women's questions. So maybe we'll do that next week. So again, hope that was helpful. Apologies again for the breadth rather than the depth, but hopefully next week it's not me, but I feel like it probably will be. We'll do something. Best of luck. See you next time. No worries, my pleasure. Oh, and sorry to mention again. So I've now decided to put this straight on the mixtape. So remember last year we did the YESPA mixtape for our revision. So that might be helpful for you again for your VIA revision. And these questions are just at the end. Okay. And it also includes all of these VIA questions that we started to do in the start of the year. See you, everyone.